So please.
Very good. Thanks for inviting me to talk about these three papers, which I think are each is very interesting. We'll start off noting that a commonality was that they were all about sea countries, and I was pleased to see that Paul took up the challenge by adding Canada to his discussion. So we had 4 sea countries. However, in terms of being about interventions affecting health, in some ways the session is misleading because I think only one arguably is about interventions affecting health in an LMIC, given that Chile is a high-income country. But nevertheless, it's a very interesting set of papers. First, Paul's paper. I think he summarized it well. I tried to summarize it here, but and I tried to do that for each of the 3 papers. But I leave it on the screen for a moment and then go on to my comments. One comment on Paul's paper I had was related to cost. I don't think costs are ever mentioned. I think the presumption is the cost of such interventions are very low. Although often when people calculate these costs, they only include the costs of the providers of the intervention, not of the private costs that the interventions have. But I would think, Paul, you would want to add something maybe in a conclusion about the costs, because presumably part of your argument is the benefits are large relative to costs, but they aren't mentioned in the paper. Secondly, there's a question of, I've quoted from the paper itself about program take up and about fidelity of program implementation in the second bullet point here. And I'm wondering if we need to understand better program take up and fidelity in order to interpret the results. I mean, might it be the case that better clinics more likely took it up earlier, had greater fidelity, and provided better services, and that affects the magnitude of what is supposed to be just evaluating this nudge, this text message. So that's a question I had. Third point in this presentation, Paul referred to this fairly explicitly in a sense. Maybe I think if I recall correctly, he claimed roughly 80% of the Chilean population uses public providers. There's the question in my mind about what's the implications of people. I have the impression in Chile, people often use public providers until they get sick, and then they switch to, or many people, at least those who could afford, switch to private providers. Does that kind of, whatever is going on is in terms of selection between public and private, does that affect how to interpret these results? And finally, it's a large enough, the intervention affects large enough share of the population, then I wonder if there are some sort of general equilibrium effects that should be mentioned. While thinking about this paper, I encountered this paper by Domgaard about a decade of nudging, what have we learned? And I thought it was useful to sort of summarize what Domgaard says and suggests that Paul and his co-authors probably want to address these points. First, he says, generally there are rather modest effects. Some of the effects that Paul presented appeared fairly substantial. Others were more modest, or I couldn't quite tell, but it might be good to address how modest the effects are. Second, and this comment I feel holds for all three papers, is the question of heterogeneity and the effects. Both Grant and Zhang mentioned on their to-do list concerned about heterogeneity. That's, in my view, also important in this case. Third, at least Domgaard's summary claims these effects are not very good at extensive margin, but better at the intensive margin. I wonder what Paul might think about that. Fourth, there's unintended spillover effects. In some way one could say part of what Graham was talking about were important unintended spillover effects. How does that fit into this analysis of Chile? And then Domgaard concludes that nudges have positive policy effects, but limited, and quite possibly they need to be combined with other policy tools. Examples are given in that quotation. Let me secondly go to Grant. This paper, in terms of my first comments, this is about health interventions in LMICs. So this one belongs in the session as the session is labeled. Here I summarize what Grant said, but Grant gave a good summary. One question I had is about the informal sector. The informal sector is rather large in Colombia. Estimates are about 60% of the workers are in the informal sector. And there's at least one paper that I note here, which finds health insurance policies result in shifts between the formal and the informal sector. And so that raises in my mind the question of if that kind of selection is occurring, how does that affect how Grant and his co-authors interpret their results? Does that kind of selection qualify in some way or suggest that they're getting bounds on the results? I'm not sure. Same question occurred to me in a way in regard to the public sector, which I don't know in Colombia, but most countries I know, the public sector has its own entire systems separate from the formal sector, or maybe they're part of this formal sector. But it'd be useful to clarify what role the public sector made. Then the way the paper is written, the insurance is basically individual. So if an individual's income goes above 5 minimum wages, they cross this threshold, if I understand correctly. And it would help me understand better the system, to understand, is the insurance system purely individual? If you're a member of a family who has a worker in the formal sector, but you yourself do not work in the formal sector, are there any insurance benefits? And if so, how would that affect what was going on? I was curious what had happened to minimum wages over time, since the minimum wages are critical for this analysis. Here's a graph of the nominal minimum wages. They're going up very steadily, but there is, inflation up to 7.6%, I think, is the highest in that period. And so I was wondering whether the change in the real value of minimum wages in any way played into people's health. They don't play into this cutoff. It's just the nominal wages that count. And I then found some evidence about fairly steady declining poverty during the sample period. Again, it seems it's kind of related to what happens with minimum wages, although not directly. And I had the same question of wondering whether the poverty changes association, the changes in real minimum wages were related to the health incomes, or if we're comfortable in just abstracting entirely from those. And then finally, back to heterogeneity, this is not minimum wages, this is unemployment rates, this is what I could easily find. This is unemployment rate for first men versus women. They differ a lot, it seems to me. And unemployment rates differ a lot by different types of education. And this brings back, again, this is unemployment. This is not who has 5 minimum wages, but I expect it's very related. And heterogeneity by various characteristics, may be important. And then third, to go to Zhang's talk about the impact of multiple chronic conditions. Again, there are a lot of these conditions. I found that your graph about the conditions after age 45 quite striking, and immediately being subjective. Of course, I looked at what they were when someone got to my age, and it was off the chart, but that's a different problem. In any case, do interesting estimates using the Charles data and find the reduction in labor force participation among migrant workers that appears significant and requires attention. Very interesting. Here's the two relations that are estimated. When I first looked at that, I wrote the first comment. These are the same relations, except for the dependent variable. And if I literally read them, it looks like the coefficients are the same in the two relations. That's not what they do. So it's probably not good in terms of presentation to present the same coefficients when you write these relations. But it does raise in my mind, these are basically, excuse me, I have a chronic cough, so I have to get some water. In a certain way, these are the same relation, except for the different transformation of the dependent variable. The first one, it can be viewed as transforming hours worked to below or above zero. And the second one is just log hours worked. And so, that raises a question of whether there's, and this may be on your agenda in your last point about further explorations methodologically, whether these really should be estimated together in some meaningful way. One possibility is, the first one is just a selectivity control for observing the second. But it seems to me further integration would be useful. Secondly, I wasn't, you have this time period from 2011, 2015 currently, and you're depending on the time varying indicators of chronic disease as well as the Z variables. And it seems to me useful to present the data on how much time variation there is. And for some of them, I would guess there's very little time variation, which may find it very hard to use the estimation procedure you have with individual fixed effects. Likewise, the third, different, not likewise, but different point about one assumption in the relations you're estimating is that there's linear effects as you increase from 0 to 1 and from 1 to 2 or 1 to 2 plus the type of chronic diseases. As you mentioned on your agenda for future work, it would seem valuable to look at differential effects by type of chronic disease. I can believe, at least in many occupations, that high blood pressure may have very little effect, but some of the other diseases concerned might have a lot, for example. The penultimate bullet point here, you also addressed in the sense of on the work agenda, but it seems to me there may be reverse causality. And you would like to be able to explore that and estimate that. Again, as I say, it's on your agenda. And finally, once again, and again, as is on your agenda, looking at heterogeneous effects in various ways would be useful. But basically, I think these are three very good, interesting papers on various C countries, which hopefully might have lessons for the rest of the alphabet. Thanks to the authors and their co-authors for undertaking this interesting work and for these presentations. I guess my final observation is I have not been able to attend all the sessions last Friday and this Friday. I've been able to attend some. I thought they were quite interesting, and thanks to Will and Eileen and whoever else was involved in organize these. But I do observe that this economist dominated session seemed to attract a much smaller audience than the others I happen to attend. I'll let Paul and Will and Zhang reflect on what that means. Thank you very much.